All right, good morning and happy May. Rabbit, rabbit. It's May Day. This is a joint meeting between Senate Health and Welfare and House Healthcare. Our meeting will run from 9 until probably a little after 10. The Senate committee will leave a little after 10. The House committee has to leave before 10 for its floor session. So we'll be splitting our time a little bit. But we're continuing our work on what's going on during the emergency with COVID-19, and we've invited the Green Mountain Care Board to come in, obviously knowing that what we begin to see is that all the little glitches in the system, whatever the system is, are being exacerbated by the COVID pandemic. And so we've asked the Green Mountain Care Board to come in and give us a report on what's happening. We have some documents online, and welcome Chair Mullen and welcome Executive Director Susan Barrett. Do you two want to provide us, you let us know how you want to go, and we'll listen to your testimony.
Super. Susan's going to control the slides, and
Okay.
I'll do most of the testimony, but we also have, besides Susan Barrett, we have Elena Barabee from our team as well. So any questions that you have at the end, we'll be happy to answer. So
Thank you. Good morning, Elena. Thanks for being here.
Good morning. I'm going to share the screen now.
Okay.
Okay, good morning, Chair Lyons, Chair Lippert, and distinguished members of the committee. For the record, my name is Kevin Mullen, Chair of the Green Mountain Care Board, and I'm joined this morning by two of my colleagues, Susan Barrett and Elena Barabee. We appreciate the opportunity to discuss Green Mountain Care Board's response to COVID-19, and thank you for the quick passage of Act 91 to help steer Vermont through these unprecedented times. And I also thank you for the opportunity to make it clear that the Green Mountain Care Board has in no way put healthcare reform in Vermont on pause. We look forward to continuing to work with the legislature to explore ways to increase scale participation in the ACO model, increase the flow of fixed payments to providers, and enhance the overall financial stability of our healthcare system. Now more than ever, we need to assess the adequacy and distribution of healthcare resources across our state and look for ways to build a stronger system in the future. We look for your support to build a system that emphasizes primary prevention, holds providers accountable for high quality care, and increases the predictability and stability of funding. On slide 2, you will see the language you passed that allows the Green Mountain Care Board during a declared state of emergency in Vermont as a result of COVID-19 and for a period of 6 months following the termination of the state of emergency to waive or permit variances from state laws, guidance, and standards with respect to the following regulatory activities, limited to the extent permitted under federal law as necessary to prioritize and maximize direct patient care, safeguard the stability of healthcare providers, and allow for orderly regulatory processes that are responsive to evolving needs related to the COVID-19 pandemic. And the 4 areas that you gave us that authority were hospital budget review, certificates of need, health insurance rate review, and accountable care organization certification and budget review. So again, thank you for your work in passing Act 91. It has allowed us to temporarily adjust regulatory structures and timelines to allow healthcare providers to quickly respond to the healthcare needs of Vermonters. These changes have reduced the administrative burden and freed up resources for frontline healthcare providers as they combat COVID-19. The Green Mountain Care Board has worked with One Care Vermont, VAHHS, the Agency of Human Services, and our federal congressional delegation to understand seemingly low grants to hospitals pursuant to the CARES Act. It became clear that during the first $30 billion stimulus round for healthcare providers and hospitals, that the formula for calculation by HHS did not include fixed prospective payments. Fortunately, the governor's office acted swiftly, reaching out to Health and Human Services and I am pleased to report that it appears that the feds have corrected this issue in the $20 billion second round that hospitals received last Friday. There are still a few small discrepancies in the formula that we're trying to account for, with some hospitals doing the formula showing that they received a little less than expected and some receiving a little bit more. But the vast majority of funds are in the hospital's bank accounts, which is essential during this time. We are closely monitoring hospital financial health, and our health system finance team has worked with VAHHS and the Agency of Human Services to develop weekly reporting. We are tracking COVID-19 financial relief and are leveraging hospital reporting to other agencies and their own boards to understand the impact of COVID-19. We have paused non-financial reporting in the budget process to free up provider capacity to fight the pandemic. We're in the process of revising hospital budget guidance and the timing. We paused hospital sustainability planning, but it is now even more important than ever. We are continuing internal development of the sustainability process until stakeholders have more bandwidth. On certificate of need, we have issued CON Bulletin 002, which is the procedure and guidance for emergency certificate of need applications to respond to the COVID-19 pandemic. It streamlines the CON process for new healthcare projects, which enhance and/or support the state's ability to respond to COVID-19. We also issued CON Bulletin 003, which is a temporary waiver of the requirement for a certificate of need for certain COVID-19 pandemic-related projects. It waives the requirement for healthcare facilities to obtain a CON for temporary healthcare projects related to COVID-19, where the facility has obtained a 1135 waiver from CMS, or the project falls under CMS's COVID-19 emergency declaration blanket waivers for healthcare providers, or if the project is part of the state's coordinated response to the COVID-19 pandemic and is directed by public safety or AHS, or the project is for the development of a hospital constructed or operated by the US government in response to the COVID-19 pandemic. A letter was sent to CMMI requesting flexibility and additional funding to be directed to providers for Vermont's COVID-19 response. The Green Mountain Care Board staff presented a draft of the letter at a public Green Mountain Care Board meeting on April 8th. The letter was sent on April 29th and was signed by all three all-payer model signatories: the Governor's Office, the Agency of Human Services, and the Green Mountain Care Board. The content of the request was to ensure providers participating in the Medicare ACO Initiative can access all available resources now and are not harmed as they look forward to financial recovery. For example, asking to allow Vermont to keep 2019 reconciliation due to CMS for the difference between the fixed prospective payments and the fee-for-service equivalent. We asked for true capitation for 2020 if fee-for-service is less than fixed prospective payments. And the letter proposes that quality metrics continue to be required under the all-payer model and tracked by providers, but requests any potential financial penalties to be waived to allow all available resources to be redirected to COVID-19 response. In addition, as it relates to the Accountable Care Organization oversight, and due to board concerns around hospital solvency and OneCare's letter requesting operational relief, the board reviewed OneCare Vermont's 2020 budget order. Green Mountain Care Board staff presented an analysis of OneCare Vermont's request on April 1st, and the board voted to amend OneCare Vermont's 2020 budget order to postpone reporting deadlines and to release funding requirements for value-based incentive funding so OneCare Vermont could direct the dollars immediately back to providers. As specified in OneCare Vermont's 2020 budget order amendment number 1, OneCare Vermont came before the board on April 22nd to provide an update on their role in the response to COVID-19. OneCare Vermont will be coming before the board again on June 3rd to present its revised 2020 budget. As the situation evolves, the board will continue to seek updates from OneCare Vermont and will make budget order adjustments as necessary. As for the rate review process, the 2021 QHP review timeline has so far remained unchanged and includes form review with DFR, rate review with GMCB, and certification with DVHA. Issuers have indicated they plan to file on time, which is next week, 1 week from today, May 8th. Federal deadlines related to QHP certification and the exchange have not changed. The Green Mountain Care Board staff remain in contact with issuers, DFR, and DVHA regarding any logistical issues that may come up as a result of the COVID-19 response, including the possibility that rate review hearings and public comment may be conducted remotely. Insurers came before the board the day before yesterday on April 29th to discuss their response to COVID-19. As for operations, we conducted contingency planning and developed a detailed continuation of operations plan, which prepares for potential staffing shortages due to illness and closure of school and/or childcare. As for the budget, we are working closely with our finance and management representatives to stay on top of all budgetary issues. We are closely monitoring the budget and are continuously looking for opportunities for cost savings, such as contractors offering discounts. And we are providing flexibility on bill back to our cash-strapped hospitals. We have offered Green Mountain Care Board resources for COVID-19 response across state government, such as using VAHHS to identify populations at higher risk for COVID-19. Green Mountain Care Board staff have skills that can be leveraged during this time of emergency, such as data, analytics, and program management. The Green Mountain Care Board continues to monitor the stability of Vermont's healthcare system. The predictable payments that are part of our state's health reform model and are proving an important line of defense in battling the COVID-19 pandemic, especially those that are truly fixed in nature and not reconciled against fee-for-service equivalents. Unfortunately, these are a small percentage as scale has not been built up. As stated by Dr. Stephen Leffler, the president of Vermont's Academic Medical Center during recent testimony, those payments are actually now our most secure dollars in this situation. Variation exists across providers in terms of the proportion of their revenues that are fixed, depending on the programs in which they elected to participate, and the number of attributed lives that fall within that program. Of those hospitals participating in the Accountable Care Organization programs in 2020, it's only between 0.1% and 23.1% of revenue that are made up of fixed prospective payments. However, a smaller portion of these payments are true fixed prospective payments, meaning that they're unreconciled at year end, for example, Medicaid. Of the 35 participating independent providers, only 7 are taking a true fixed prospective payment. But all program participants will receive supplemental payments, and that sums up to a total of approximately 1 million under our current model. Maximum scale is considered to be approximately 85% of Vermonters. And please remember, both participation in the model as well as electing fixed prospective payments is voluntary. This is a coalition of the willing. We continue to seek improvements to the financial stability of Vermont's healthcare system in the near and long term. For the short term or current fiscal year, we are analyzing opportunities to modify the Medicare Accountable Care Organization Initiative to increase fixed prospective payments available to providers. A Green Mountain Care Board meeting was held on April 29th to understand how insurers are supporting our state's response to COVID-19. OneCare Vermont is currently piloting fixed payments with Blue Cross Blue Shield. We continue to collaborate with the Agency of Human Services to ensure hospital solvency. We continue to monitor OneCare Vermont's response to COVID-19, including the impact on participating independent providers. Their presentation on a revised 2020 budget is scheduled for June 3rd. We continue to support the expansion of telemedicine, both to ease our healthcare workforce shortage and to provide Vermonters access to appropriate care. And I can tell you that telehealth is working. At 8 o'clock this morning, I had a telehealth visit with my rheumatologist as I finished battling a Lyme disease-induced arthritis. And it's working. And the doctor assures me that everyone is still getting quality care. And as another example, my granddaughter was bitten by a tick a little over a week ago now, and using FaceTime, my son, in consultation with her pediatrician, he looked at the tick bite and prescribed a one-time dosage of oral antibiotics that my son was able to drive to CVS's drive-through to pick up. So it was contactless delivery, and it worked out great. And these are the stories we're hearing across the state as we expand to telehealth. And I think back to the days in the Senate, the first telemedicine bill that we passed, and how skeptical people were of the possibility of it working. But out of necessity brings invention. So we're doing really well with telehealth, and we hope that continues. It really will help us with our workforce shortage. We're also hopeful that during this time of pandemic that people will be sick of living in urban environments where they're packed next to each other and stacked on top of each other and in apartment buildings, and think of this as an opportunity to take a great job in the healthcare system in Vermont. In the medium term, we continue to work on hospital sustainability planning, which is now more important than ever to refocus on the financial stability of community health systems. Communications continue on the benefits to providers of fixed prospective payment program that are already in operation under the ACO Coalition of the Willing. We are exploring strategies to increase scale. Green Mountain Care Board will continue following up on the scale survey and strategies on how to motivate self-insured plans to join the model. State employees and teachers would be a major piece in the expansion of the reform efforts, and thus far their failure to participate is a major impediment to the growth of scale to create a successful model. We continue to explore possible changes to the Medicare Accountable Care Organization initiative under the all-payer model. These changes include geographic attribution methodology, which is striving to have it based on residency instead of primary care relationship and claims history. If we get this change to geographic attribution, it will increase scale, which provides more opportunity for fixed prospective payment. We seek true capitation payment. Right now, fixed prospective payment is reconciled against the fee-for-service equivalent at year end and poses a financial risk to participating providers. True capitation mirrors Medicaid's fixed prospective payment program. Changes of this magnitude will take over 18 months for CMS to operationalize. In the long term, we have begun working on the all-payer model 2.0, while at the same time also considering a request for the extension of the current model. We expect COVID-19 to impact our health system now and into the future, not just in terms of financials, but also in terms of scale and quality. It will take time for these effects to be known, quantified, and analyzed. The Green Mountain Care Board continues to explore methods to increase fixed prospective payments. Consider building on the hospital budget process to establish global budgets and to invoke provider rate setting authority. We are leveraging lessons learned from other models like Maryland's all-payer global budgets and Pennsylvania's rural health model and global budgets. Appendix 1 of today's PowerPoint briefly outlines these two programs, and Appendix 2 provides you with a full list of resources. So at this time, we will open it up to your questions.
Thank you very much. That was a comprehensive overview of a lot of different things going on. And I'd like to concur with you. I had a telephone conference call for my last provider appointment, and it was just at the beginning of our request for isolation. So it was by telephone, not video, but I agree with you. It was really very effective. And about a similar issue, Chair Mullen, about Lyme disease. So we're on the same page.
Those nasty little ticks.
They are terrible. So I do have a couple of questions, and they're pretty general questions, and then we can move ahead with Representative Lippert and other members of our committees. But the language that's in Act 91 is pretty clear that it's allows for you to make adjustments as during a response for COVID 19, but it doesn't restrict any of those changes to a time during the emergency. And I'm asking you that question, but also reaching out to Jen Carby if there's a question about what the meaning of the intent is there.
Well, our interpretation of the intent is that it's up to a 6-month period following it. Obviously, we're itching to get back to business as usual too. We don't like doing things remotely, but this may have to occur for a while, and it might be best for the safety of people if it does, we are allowed to continue with video board meetings and things like that for a period of time.
I guess I was referring also to the timeline for budget decisions for hospitals.
Oh, okay, sure.
And those kinds of decisions, and whether or not you agree that this is to respond to the effects of COVID, not simply within the time of the emergency declaration.
I would agree that it extends to the pandemic. What we're looking at as far as hospitals for the financial reporting, which normally would occur at the end of this month, the initial reporting, we will delay likely till July 31st, which still would give time. Keep in mind that unfortunately, this year's budget process is not like the past, because you cannot go based off of the existing current trends because they've been wiped out, with many hospitals losing 60% of their revenue, and it's a totally different world. And what we don't know is if there will be pent-up demand, or if there will continue to be a continuing fear among the population of going to hospitals. And we certainly hope not, because we've heard stories from, for example, Steve Leffler told me the story of his neighbor that broke his foot and was unwilling to go get it set. And one of the things that people should be aware of is that hospitals, more than anyone else, understand how to properly clean, how to properly wear masks. Not everybody properly wears their masks. We see it on television all the time. Having a mask that's not covering your nose as well as your mouth doesn't mean anything. And even if you have one of these great plastic shields, which are phenomenal, you still should be wearing a mask underneath that. And hospitals know the value of sanitation and everything else. So hospitals around the states have been working on plans and have developed plans where they would be able to, for example, take temperatures of people coming into the building, to create separate entryways for different things to occur. I was talking with Dr. Brumstead yesterday, and he had an announcement at 9 o'clock this morning. I don't know if we've received that email yet, but basically just announcing.
I think it's 10 o'clock. I think it's 10 o'clock.
No, he told me 9, but it's probably 10.
I heard this morning it was 10.
Yeah,
I heard
10.
it.
I don't think it's time yet.
Okay, so I won't talk about that.
No. Okay, you can
I
talk
thought that
about
I
it
might
at
be
10.
able to, because he had told me 9, but you know how that works. We don't want to get out in front of them.
No.
But basically, what he and I were talking about is, things that have been delayed, like the insertion of a stent in someone's heart and things like that. We don't want somebody dying because they're afraid to go to the hospital. and they can make it safe for patients to go and get these things done. So hopefully we'll hear within a short period of time that hospitals will be able to do other things than emergent surgery. And that's important because you don't want somebody, for example, to not have a mammogram for a long period of time and end up dying from breast cancer, or somebody not having a colonoscopy and dying from colon cancer. I mean, these are the type of things that we need to do safely. And I think all the hospitals in the state of Vermont have worked very diligently to create plans that will allow for the safe reopening of these preventive procedures and non-emergent care. And that's important. I mean, just a few weeks ago, they wouldn't have been able to do it because we didn't have access to enough PPE and masks and everything else. And that fortunately is moving in the right direction. And as long as that continues to moving in the right directions, hospitals should be allowed to begin to get back to some sort of normalcy, because quite frankly, we don't have enough dollars in the treasury to keep them afloat if we keep them closed forever.
So Kevin, the question, my other question, I have two more questions. One is, you're talking about the prospective payment process that is so important to us. And you talked about that only 0.1% to 23.1% is now that, which means, but that also then includes all the attributable Medicaid lives, but it also should be including Medicare, and then a little small, very small amount of private carriers. I'm actually surprised at that number, given our Medicare population.
Well, keep in mind that some hospitals have been late to the table, and many just joined for Medicaid only fixed prospective payments. So you're in an area of the state, Senator Lyons, where there's been greater take-up, but other areas of the state were a little bit slower. Keep in mind that UVM was one of the leaders in this transformative move, trying to move to a different system of healthcare. So, you know,
Yep.
I just want to relay a story of, because Senator Lyons, you remember, and we've talked about this when we were on the finance committee together, and Tom Hubner came in with a proposal for a global budget pilot at Rutland Regional Medical Center.
Right.
And he and I exchanged emails. We're doing that regularly anyways, because of he's still working for the state on the Springfield hospital situation. But the email that I sent to him was, wouldn't it be incredible right now if we had global budgets in the state of Vermont, because then our providers would still be getting their regular payments and we wouldn't be in the crisis that we are in. And, you know, we kind of lamented that fact, and we continue to look at ways to try to do more with fixed prospective payments, and to look at the successes that Maryland has seen and possibly try to tie in the efforts of OneCare into an expansion into some global budgets that might actually prove even more helpful over time. So, but that's something that's going to take time, research, and stakeholders at the table. And right now, the healthcare community doesn't have the bandwidth to come to the table to even have that discussion.
Well, I know that we've talked about this previously and recently, and I think that our committees together will be looking at how we can support initiatives for global budgeting. I think what is best for me to do at this point is to ask Representative Lippert if he has questions, and let the House maybe ask some questions. The Senate can be here a little bit longer. So if any of you have questions, just, raise your little blue hand and we'll find you.
Yeah.
Bill, go ahead.
Yes. Thank you, Senator Lyons. Yes, Kevin, so two broad questions. The first really has to do with the fiscal solvency of hospitals in the current situation, because we really do need to, that needs to be in many ways priority number one in order to get to future modifications in our financing system. And my question in part is that it seems that the federal monies available to hospitals in Vermont is going to be far from sufficient to fill the gap in costs from the dramatic drop off in scheduled planned visits and surgeries, et cetera, which we know has been done to accommodate the need for COVID-19 response and the additional expenses. Does the Green Mountain Care Board feel like it has a clear understanding of what the current solvency issues are for the system of hospitals in Vermont? So that's number one, I think the most important question. But then I would also give you the opportunity to say, in terms of the Act 91, which I'm glad we all collaborated early on and created the flexibility for you as well as for the Agency of Human Services and others. Having now been in the midst of using that flexibility, are there areas where, in your view, it's clear that there should be a further legislative initiative in order to address the issues as they've begun to emerge?
Sure.
So there's really two separate questions,
Yep.
but if you could respond to both, I'd
Sure.
appreciate it.
Great questions too, Bill. Thank you. The first one relating to hospital solvency. What has been put in place is a system where weekly hospital CFOs transmit data to VAHHS, and we set this up with the Agency of Human Services, led by Corey Gustafson on this effort, and Ina Backus, ourselves and VAHHS, to create a weekly template that measures the hospital solvency at that moment in time. So for example, on this week's that we'll look at today, we'll see the influx of the new federal dollars that came in last Friday, and we'll be able to change what the assessment it is on the days cash to zero. It's no surprise. We've been very reluctant to post any of this information because we don't want anyone to get scared that a hospital might likely close. There's only a few hospitals that are in that, what we would call the red zone, where they would have trouble after a month and a half. And so it's no surprise that the biggest one is Springfield, and the state of Vermont has had to help Springfield. And, it's been very clear that the state of Vermont didn't want any hospital to close in the middle of this. It's also very clear that, unfortunately, the COVID-19 process has put even more downward pressure on Springfield, because Dartmouth itself is losing $20 million a week. And they're hesitant to do the type of things that many people were hopeful that they would do, such as repaying all the dollars that the state of Vermont has advanced, repaying the dollars owed to the federal government, and making at least some type of payment on the bank loan that Springfield has. And also, Springfield doesn't have a lot of time now without being able to do these other things at the hospital. So Dartmouth, even once they pull the switch and say we're willing to do it, the process in New Hampshire is different in that they have to go through a review from the Attorney General's office that is an antitrust review. And that would probably take 120 days at the minimum. So there's a lot of things that are going against the tide there. And that's the one that I worry about the most. I think as long as in the next period of weeks, and I'm not saying months, in the next period of weeks, hospitals begin to be allowed to start to do some other things, then we will be able to keep them out of the immediate crisis. But the problem is going to be that it's going to be a different world than what they're used to. So I know that we've sent you already the information on the furloughed employees and things like that. And it's really going to depend on people's willingness to go back in and have certain types of healthcare, on how successful we will be getting their financial solvency back in line. It's probably going to take a matter of years to put people back on firm financial footing as far as their days cash on hand to protect against something like what we're experiencing now. And we're just going to have to be very careful about how we approach that. The second question, the one thing that
Can I just ask a
sure, go ahead.
quick follow-up on that? Because the assumption from what I'm hearing from you is that that hospitals are going to need to be able to begin to provide the services which they've reduced dramatically in response to the COVID situation, and you're talking about to begin to do that within a period of weeks. Is it so that this is going to require? I'm assuming this requires careful communication with the governor's office.
Yes.
In terms of the executive emergency order, and I don't think you're announcing today that hospitals are doing that. They
have been communicating, and what I'd like to say is that anything past the beginning of June is going to be problematic unless there are additional federal dollars that come down the pike. And I think if there is a flare up and hospitals aren't allowed, then there is going to have to be federal dollars coming down the pike, or the state is going to have to try to pony up scarce resources, which the state of Vermont doesn't have.
Right.
So,
let me ask this question while you're there. We understand that some of the reimbursement process can take as long as 3 to 6 months, or even longer. And is the assessment of sort of the problems the financial difficulty and solvency, the problems that their hospitals are having, how much of the money that's available through the initial CARES Act, how is that being accounted for? I know that their hospitals and clinics can bill back to the federal government to have money flow in. Is that all being taken into account?
Yes, and basically the hospitals have to agree to the terms that HHS has put in place. And but to give you, there is no manana of pennies from heaven coming from the federal government. Just to give you an example, the first payment to RRMC was 5.3 million, and yet they lost $7 million this month.
Right.
So, I mean,
potentially the elective procedures could help, but we can't count on that. And I did hear you say that.
Yep.
Representative Rogers has a question, Bill. Is that something we can allow for right now?
Well, I'd be happy to, but I really would like to hear Kevin respond at least briefly to my question about whether there's anything further from the legislature that the Green Mountain Care Board specifically would like to recommend or have us consider. And then I'd be happy to have Representative Rogers.
Okay,
Sure.
and whether they want us to consider it or not, we will be discussing something.
Okay, so the one thing that I would really urge you to consider, Robin Lunge sent some language, I think,
Yeah.
to the two of you and
Yeah.
to Jen. And basically, she feels that there's a hole in the language on telehealth that really needs to be addressed.
I think we're on top
Hopefully
of
you'll
that.
consider that.
Yeah,
We're,
I think
we're,
top of
we're
that.
on that. We're doing that. We're working on that. We're
We're
working
working on
on
that
it next
actively.
week, next Tuesday, actually.
Yeah.
So that's good to know. Important. Sorry, Bill, go ahead.
No, given our time, let's open it up to other questions from House members.
Lucy,
Thanks, Kevin. I was just wondering if you can help put into perspective for me how much do hospitals pay to OneCare for dues?
So it depends upon the size of the hospital, and it's over the map. But Elena, can you give Representative Rogers the total out of this year's
the
budget?
total is around $50 million. I can pull up the exact amount, but it's around 50 million.
50. So is that, I mean, is that just to try to like put that number into context? That's pretty comparable to the total that Vermont is getting from the
I think one of the, to put it in context, there were some analyses done by board staff about how much the hospitals would be losing on a monthly basis if their revenues decreased by 50%. And that number was 115 million monthly. So 50 million over the course of the year to meet a gap of 115 million monthly. And I think that OneCare has been talking about how they can return some of those dues, and we'll learn more during the June 3rd presentation once they've kind of finalized their renegotiations. So that number could change, but that was what was proposed on their original budget.
And then the total amount that Vermont hospitals have received so far from CARES is also around 50 million, or what would that total amount be?
do we know? I guess is the question.
We can get that number to you. I know we are tracking that, so I don't have it off the top of my head. Do you, Kevin?
No, but I think what Representative Rogers is referring to is the federal government gave 50 billion in the two rounds, 30 billion the first round and 20 billion the second, but that's across the whole country. And so we have that data and we can get it to you. Do you want me to just email it to the chairs and they can distribute it?
Well, if you send it along to Nellie and Demis, then we'll post it and it'll be available to both committees.
Okay, and
That
we'll
would be
break it
great.
down by rounds and you can see.
Okay, good.
Thank you.
Any other questions? Representative Page.
Yes, Kevin, couple of questions here, kind of related to what Chairman Lippert was saying. Do you foresee, besides Springfield, the possibility of closing hospitals in the future to save our healthcare system in Vermont? And in relation to that, I guess, do you see UVM and Dartmouth playing a greater role, Dartmouth Medical Systems, playing a greater role in partnership or merging with some of these hospitals in Vermont? Thank you, Kevin.
Thank you, Representative Page. I could see in the very long term a much bigger role from the academic medical centers, but I don't think that you're going to see anything in the short to medium term with the sudden new reality for them as well, that their resources are drying up quickly. And so I do worry very much about our rural hospitals. They were under pressure beforehand, and it will depend. There could be, and I hate to call anything a positive in what we're facing now, but I would like in my heart to believe that as people are seeing what's happening in big cities, that there might be a renewed desire to move to more rural areas like Vermont. And if that happens, that could help our state with our demographics in very big ways. And it would help not only have more people seeking service that would create better revenue for the hospitals, but also would help to attract more healthcare workers, especially given the shortages that we're facing. But the reality is it's going to take time for that to happen. And we don't know if, or if there will be a continuance of the demographic trends that we saw previously with people not wanting to live in the more rural areas and a continued population decline. And so what has to happen is hospitals have to readjust and redo their thinking. And I'll give you an example of a hospital that if you had asked the Green Mountain Care Board about a year ago, that we would have been very worried about, it was Gifford Medical Center. And they really put their feet to the fire, and they came in with month after month of positive financial results and really had changed the navigation of the ship to the point where they were really doing very, very well until this current pandemic hit. And then it changed their world just like it changed everyone else's world. But if hospitals are willing to readjust and realize that they can't do the same things that they did 6 years ago if there are fewer people living in their area and the demographics have changed, then there is hope. And telehealth is one of the biggest things that could help to try to keep a revenue stream, keep quality healthcare, and keep people open and available to take care of people in rural areas. So it's not a good answer to the question, Representative Page. It's one more of hope than anything else.
Can I add, this is Susan Barrett, just very briefly, we talked about this in our presentation, but the board staff before the pandemic was working on sustainability planning with the hospital specifically. We're really looking at sustainability planning for the healthcare system at large right now. And what we're doing is working internally on that work. We are obviously waiting, as Kevin said, until there is bandwidth for the hospitals and other healthcare providers to work with us on how we go forward. And COVID-19 has been a giant disruptor, but as we've talked about before, there are things that are coming out of this that are showing and laying bare what are the problems with the current healthcare system and how do we move forward. So I'll just remind folks that we are internally working on those sustainability plans, and we'll update you when we have more information.
Terrific, thank you, and keep us posted on that. Yeah, because as all of this is unfolding, we're seeing the warts in the system, regardless of the system. There are a lot of systems with problems, and they're just showing up more and more. Any other questions from House members? Because I'm being aware of your time. You've got a few more minutes probably.
Thank you.
I do have a question, or it's a comment related to what we were just talking about. And as you're looking at geographic distribution and how to sort of change the payment process based on geography and the budgeting process, can you talk a little bit about that? Because I think it does very much relate to what Representative Page's question and Representative Lippert's questions were.
You want to take that one, Elena?
Sure. Right. So Medicaid had piloted a geographic attribution methodology in St. Johnsbury last year and has since expanded that methodology to the entire Medicaid program. And I apologize for the crying. I have a toddler who's having some trouble.
Take your time.
Anyway.
If you need to leave, I'll bet Susan and Kevin might be able to cover for a bit. Go ahead.
I think her husband is taking care of.
Oh, her husband is.
Yes,
Okay, that's
the
good.
The other parent.
Okay. Parenting
So
101.
yeah. So the Medicaid program is doing this geographic attribution methodology now, which is instead of relying on claims-based and primary care relationships to drive the attribution, it's really taking a population perspective. So really treating the entire population and creates incentives to bring people into the office and to get prevention who otherwise may not be entering into the healthcare system. So there is kind of this tension on cost savings and additional cost growth, but in good spirit. So I think learning through that process, we're in conversation with Medicare, CMS to kind of think about whether or not this could work in that program. There, no promises, but it's just kind of an ongoing conversation and something that has been interesting to them.
Well, it would seem to me that it links in directly with the concept of global budgeting for individual hospitals and may help to sort out some of the differential between the larger and the hospitals and our critical care. Yeah.
Right, because then you're really treating the population and you can tie that global budget to a population. It becomes a much simpler method than when you have this, strange bifurcated population that you're trying to figure out who's attributed or not. And
Right.
That's not something that we want our providers to have to deal with.
Any other questions from?
Can I just,
No,
Senator,
go
Hey,
ahead, Bill.
well, as the co-chair, I'm going to assert my co-chairmanship. So it occurs to me that another issue that, and I'm not sure if you at the Green Mountain Care Board are tracking this or will be, but the shift, given the incredible unemployment situation that we have now in Vermont, it's unprecedented. The impact that could be having on commercial plans and the provision of health insurance to Vermonters through commercial plans through their employment, possible significant increases in Medicaid and or shifts around the access to health insurance. And I'm wondering if that is something which you are actively able to monitor, because I'm aware that we didn't authorize a new study, and probably it's appropriate that we didn't at this point, but it helps us to understand the range of access to health insurance for Vermonters, and with previously one of the lowest uninsured rates, although high underinsured. Are you able to track those changing demographics, if you will, of health insurance access?
So we don't have immediate real-time tracking, but what we have, for example, we had MVP, Cigna, and Blue Cross all at our meeting on Wednesday. And it's been very minimal, the amount of drop off in the commercial market. I think it was around 500 people for Blue Cross Blue Shield of the well over 200,000 Vermonters that they're covering. And so there will over time be more of a Medicaid population if people don't return to work and remain on the jobless lists. Then Medicaid will definitely pick up. I think right now what you're seeing, Chair Lippert, is that because of what's happening in the world, people are doing everything they can to stay insured. And it's not something that you might think of, what can I drop quickly for my household expenses because I've lost my job. People are looking elsewhere because they realize that they may need health care. And so, so far, and again, knock on wood, so far we haven't seen a decline, a significant decline in the membership in private insurance. Over time, we're likely to see some of that, and we will monitor that. We will be monitoring the whole insurance framework, because one of the last things that we want to let happen now is that insurers are allowed to just increase their reserves. And now more than ever, there's an important time for reserves. And I believe that when you have a pandemic, that might be a time where dipping into those reserves might be the most prudent thing to do to help the healthcare system as a whole. But so far, we just don't have enough data to try to push that conversation forward to make that happen.
Well, I hope there'll be active conversation between the Green Mountain Care Board, the Department of Financial Regulation, and the insurers as those issues come before you. So
Yeah, we've been having those conversations. I think that Commissioner Pichek is a little bit more cautious than I am, and
you've told your job.
he may be much more right than I am. But I would just say that my car insurance company didn't wait till after May was finished to make sure that I didn't drive. They sent me a check for 2 months reduction. It was only like $54, but still, they did that. And if there had been a process where we could have required payments to go out to providers based on a percentage of what they had done leading up to entering this, that would have been helpful. But I guess I'm over what I initially wanted to happen. And now we have rate cases coming in. Currently before the board, we have 2 large group cases, one from Cigna and one from Blue Cross. Next Friday, we'll have the QHP filings, and our actuaries and our staff will be working with the insurer staff and actuaries to try to get a better handle on where this is. What Commissioner Pichek reminds me is that we don't want to have herky-jerky reactions where rates are held at 0 and then get jerked back up in a year from now either. So we're trying to figure out a way to manage this, but to make sure that things aren't left off the table that should be left on the table. And unfortunately, the lion's share in Vermont is Blue Cross Blue Shield, and that is a not-for-profit company. I worry more about for-profit companies, and I see what they're doing in the stock market now, where they're one of the few industries that really hasn't been hurt in their valuations because their profits don't appear to be in jeopardy. And that bothers me, but I guess I'll get over that, and we'll work through this, and we'll do it deliberatively and appropriately.
So thank you for that. And we
I see the
did,
time is such that we probably, as House members, need to head to our House session, and probably we're all going to be late, but
all right, well, walk down the
get
hall.
ourselves away from this healthcare discussion.
Okay, thank you. Thanks.
Thank you. We'll see you.
It's
Good seeing everybody.
All right. So Kevin, I was going to say that we did take some testimony on the issue around private insurers, in particular Blue Cross and Blue Shield. And we have asked to have some information come back exactly as we're hoping we'll get information back about hospital solvency. And so yes, the concern around not-for-profit or non-profit versus for-profit organizations is one that we all have. So here we are, just, I haven't seen my committee like this in a long time. We've been meeting jointly. So it's an opportunity, I think, to ask questions, and Jen Carby is also here. So, and I'm going to ask committee members, do you have any questions for Green Mountain Care Board folks? Rich, go ahead.
So Kevin and maybe Susan, how the feedback to you is, how quickly do you hear back from the insurers and the hospitals, knowing that the next 30 days will probably be the most telling because most hospitals are 30 to 60 days behind in their billing. So we will, in the next 30 days, really have a way better handle on. Do they feed back to you weekly, daily? How does that come?
So the hospitals we're getting information weekly on. The insurers, it is not as frequent as that, but we did just have an update just 2 days ago. And they talked about the areas where they had seen a decrease in money going out. specifically hospital and provider-based care, and then where they saw increases. So for example, there was an increase in the amount of claims related to prescriptions, but you would assume that would occur because if you recall, they went to a 180-day fill policy to help consumers and keep people out of having to go out to get those medicines. So you would have expected that. And so I would expect that when we see the numbers coming in next month, that there would be a decline in those because they had bought those prescriptions ahead.
Okay. Senator Ingram
Thank
and
you.
Nolan is here. Good. Okay.
How involved, you mentioned scale of one care, having an impact on the fixed payments, and how involved is the Green Mountain Care Board with trying to help One Care scale up, and how important do you think that's going to be in the recovery from this pandemic?
So we continue to try to strategize on how to get more members of the Coalition of the Willing. One of the most frustrating things of all is seeing that state employees and teachers have not chosen to get involved in this, really a brave test of whether or not we can change the way medicine is delivered in the state. And it's kind of disheartening because that is such a large portion of our population. And until we really get scale built up so that the majority of people being seen by our medical providers are attributed lives, really not going to have a true answer of whether or not this experiment works. And so I think that one of the things that is encouraging is the number of self-insured plans that Blue Cross has that are now willing participants. And as others see that there was no nasty hit that these plans took by signing up for this program, that others will join as well. And remember, it has always been a coalition of the willing. That's one thing, Senator Ingram, that you could really help. I actually think that the legislature represents the state and could do a great role in trying to promote teachers and state employees to joining this effort to make it work.
So you've
I
just,
agree with it very
yeah,
much.
we're all in agreement with you. Our committee has been looking at a bill that no one likes called S-290, and it has in it a provision that encourages those two organizations to evaluate how best to participate, or at least to have a conversation. So we're on it. Any other questions for Kevin or Susan? Jen, I include you in that. Are you good? Okay. Senator Cummings, Senator McCormick, you're okay? Nolan, questions? No. All right. Well, Kevin, do you, or it's 10 after 6, 6 after 10, excuse me. I got my numbers back.
It feels like it's 6 o'clock to me.
Doesn't it?
I agree with you.
Well, who wants to make the announcement that we have heard about with regard the press conference that VMMC is having right now? Do you want to offer that, or shall I? Or
You can go ahead and do it.
oh, good. It's very simple that the University of Vermont Medical Center is announcing a deficit during the COVID crisis of $150 million. So that that's something that you all will be seeing at the Green Mountain Care Board, I'm sure.
Yep.
And how that sugars off in terms of money coming back or not. And I know that they're also announcing some pay cuts, administrative pay cuts, incentives, retirement, as well as pay cuts for some of the doctors and providers. So it's not a happy message, but it wasn't unexpected. I'm
No, it
yeah.
can't be unexpected when a fifth of our economy is spent on healthcare. I mean,
Yeah, exactly. Which is all the more reason why encouraging prospective payment reform is so critical, and all of which why it's so critical to have global budgets for our hospitals, so to offer greater predictability for the financial predictability.
I will
So-
give you a little humor that I thought might lighten the mood when I was talking to a hospital CEO yesterday, but he didn't take it as lightly as I meant it. And what I said to him was, I guess we've eliminated all unnecessary utilization from the system.
Oh, wow. Okay. I guess that's a joke.
It was meant as a joke. I thought
I
it was
know.
a little humorous. I don't
All
know.
those MRIs that you don't really need and all that.
Yep.
Any other questions? Listen, our committee will be discussing how, and I think with House Healthcare, obviously, we'll be looking at how we might help advance some of the things that we've been talking about today. So including hospital global budgets, but going back again to the NEA and the VSEA and how we can encourage them to evaluate best practice, which is what the forward prospective payment process is. And it will help. It will help both access to healthcare services and also solvency for those providers in the system. So,
Well, we really appreciate everything that you're doing to try to push the conversation forward. So thank you.
whatever we can do, and we thank you for your work, all three of you who are here, and we're very pleased that you've been able to give us the time that you have, very much. Okay, so committee, just a couple of things before we sign off. I've heard conflicting reports about our meeting times and availability of meeting times. Next week, we are scheduled for 2 meetings right now, but I heard yesterday during our all Senate discussion that we might have additional time for meeting.
Wait, may I just say, I don't know if you saw that Senator Ash sent an email while we've been meeting saying that we're having a floor session we're having a all Senate call first thing Tuesday morning and then a floor session at 9:30. So I guess.
Okay, right. Well, right now we have a meeting scheduled for Tuesday that we'll have to juggle and move, but the House is meeting on Wednesday. So whatever happens interferes with either the House or the Senate meeting times. So we'll be changing our meeting schedule to adjust to the all Senate sessions. And so that's a heads up, Nellie and Demis, because you've already been sending out invitations for folks. Hopefully we'll get onto a regular schedule so we don't have to have continued upset. This has been a constant problem. So we'll communicate with Pro Tem's office to see what we can do there. So we will be meeting next week. I'm trying to put time in place for our committee to have a discussion about possible legislative initiatives. And I've talked with Jen, I've talked with Maria Royal about some proposals that we can put forward on healthcare. So we'll continue to do that. And as I suggested in a little email I sent out to you over the weekend, that if you have ideas for recommendations to appropriations, recommendations to joint fiscal, or recommendations for our own committee on legislative proposals, it would be helpful to get those sooner than later, because I have a feeling that the next few weeks are going to go very fast for us. And then lastly, I think I did make a list of the Pro Tem's office asked for a list of legislation that we thought was important to pass this session. I included in that some of the things we're working on now, just as committee bills, I labeled it committee bills. But also some of the legislation that we've passed is currently in the House. I think all of the bills that are currently on the Senate calendar, and then some House bills that we have, some we have considered, some we have not. Most of them we haven't even looked at yet. So I think we'll be able to look at some of those bills. I haven't had any feedback on that note I sent out. Yes, sir, Mr. McCormick, Senator McCormick.
Thank you, Madam Chair. With so much morning time being taken up by floor time, are you considering having this committee meet in the afternoon since all other rules are out the window? Are you thinking of us meeting in the afternoon?
If we have to, we will. I mean, I personally think that I know that Senator Cummings is waving at me, and I agree. So is Senator Westman. There are other committees, and you were also on one of those.
Yeah, what I was going to say is that appropriations is getting started on the new improved Budget Adjustment Act. So
Yeah,
we're not
education
going to have a
meets
lot of
occasionally.
afternoon time.
I mean, this is exactly why it's important for us to meet. We've taken more testimony, I think, than any other committee, and we certainly have a great deal of information and help that we can offer. Maybe it's not wanted, but I do think that we should be looking at that and focused on that as one of our priorities. So, and in that case, we really need to meet separately from the House. So we need to have some time as a Senate committee to do that. So, and I know that Joint Fiscal is meeting at different times. Senate Finance, I don't know what your schedule, you're muted. Senator Cummings, you're muted.
I'm muted. Joint Fiscal is trying to hold to Mondays at noon.
Okay.
Except when the Senate bumps us.
So,
yeah,
Or
I
the
know.
full
I know.
House. We chose
so are
Monday
we
because
meeting?
no one else meets on Monday.
Ann, are we meeting this Monday at noon or at 8:30 in the morning?
I don't know. Whatever Chrissy tells you or Teresa's when we're
Okay.
meeting.
All right, all right. I thought we'd settled on 8:30.
I think it is 8:30 on this. That's right, because I hate 8:30s. I made that comment.
Ditto,
Yeah.
ditto.
Okay, and Nolan is shaking his head. So yes,
That's what
it
I
is
have.
8:30 on Monday.
That's what I have in my schedule.
All right, so, and I can't apologize for what's happening to the meeting that we currently have scheduled for 9:30 on Tuesday. But if it's true that we just got an email that totally upsets our schedule, then it upsets our schedule and we go from there. So I'll be working with Nellie and Jen and Nolan and Bill Lippert, because it was a joint meeting and it's an important one for us because it does relate to some of the legislation we wanted to put together. So we'll be shifting that and we'll see how it goes. You know, the more things change, the more they stay the same. So anything else, folks?
No.
We're all good. Thank you all.
Thank you.
Okay, thank you.
All right.
Time to
Nellie,
go to the next one.
we can leave the meeting. Take care.
All right, ending live stream.